Hey, everyone. Welcome back to another episode of Mind, Your Body, and Soul, the Healthy Podcast. I am Joe Swart, and as always, joined by me, Mr. Incredible, Mathias Sweet. What's going on, Mathias? How you doing?
Nothing much, Joe. Just out here, working like usual.
Oh, yeah, we working. So we have a great podcast today. A lot of great information, as always. But before we get into our information and our guests, let's take care of some housekeeping. Remember, Mind Your Body and Soul is an educational podcast that focuses on all things health related to help our listeners learn more about the various health topics and information they may not have access to. We seek to inform, empower, uplift, and mobilize our listeners to become the healthiest versions of themselves. Mind Your Body and Soul is available every Wednesday, most of the time on our website at www.nmcpodcast.com. And remember to visit our parent website at neighborhoodmedicalcenter.org. And remember, our podcast is also available on Anchor, Breaker, Radio Public, Pocket Cast, Spotify, Google Podcasts, and of course, right here on YouTube. So make sure you subscribe to this channel, like this video, place a comment in the comment box and make sure you share it so as many people can get this information as possible. All right, so great interview. We are talking to Dr. Matthew Lawson, who is the stroke medical director for Tallahassee Memorial Hospital. Welcome, Dr. Lawson, to Mind Your Body and Soul.
Thanks for having me.
Yes, sir. So I did some research on you, and I found out that you a pretty big deal around here. You've done some incredible things. So congratulations on all that you have done, because you really have truly done some remarkable things in the field of helping to prevent strokes and helping people be healthier in that area. And you've done some remarkable things to help our people in our area. So thank you and congratulations.
Well, thanks a lot, but I can't probably take all the credit because what I do is just a small piece of the pie, and everything that we do as far as stroke treatment is really a team approach. And we've got a team of multiple doctors, multiple nurse practitioners and physician assistants, and then like hundreds of nurses, paramedics, EMTs, techs in the lab, you name it. What we do at Tallahassee Memorial for stroke, it's really a team thing. So I kind of look at myself as maybe like the offensive coordinator or something, but there's a lot of people doing a lot of the work.
Yes. Well, congratulations and thank you to your team and everyone at TMH who just helping our community, because without you all, things may be a lot worse, but with you all, we know we can get better, and there's brightness on the horizon. So thank you all.
You're welcome.
Yes, sir. So, okay, Mathias, let's do this. You got the first question. Let's kick this off.
All right. Can you give us some information about your medical background and why we should educate about stroke prevention and treatment?
So for my medical training, all of that was done in Gainesville. So I am a Gator.
Okay.
Wrong territory.
Hey.
I know, but I came up to Tallahassee because there's a lot of need for what I do, and it turned out to be a good partnership. So I did my medical training, medical school in Gainesville, and then a residency in neurosurgery in Gainesville, including a fellowship in something called endovascular neurosurgery. And that's really a field where we treat disorders of the blood vessels of the head and neck through minimally invasive means, usually through the artery in the leg, the femoral artery. And a lot of what we do now is stroke treatment. And things sort of evolved, and our group kind of became the dominant group taking care of patients with stroke in Tallahassee. And so that's sort of my background. I think the second part of your question was, why should we be educated about stroke prevention and treatment? Well, because it's a big problem. We have, it's the number one cause of disability in the U.S. 800,000 strokes a year happen. Every 40 seconds, somebody in our country has a stroke. And every 4 minutes, somebody dies of a stroke. And so it's a big deal. It's one of the leading causes of death, but it is the leading cause of adult disability. And unfortunately, it's more common in the South. The southeastern United States is called the stroke belt because we have a disproportionate number of strokes compared to the rest of the country. And so I think it's important that everybody in our community know a little bit about stroke because it happens here, and you need to seek treatment quickly, and that's really important.
Right. The stroke belt. I've never heard that before. Because we're pretty familiar with the disparities, especially us working in HIV/AIDS prevention. So we know like the diabetes map and the HIV map, and a lot of the disparities is heavy in our region in this Bible Belt, but never heard stroke belt before. That's new.
That is
Well,
new.
it's real. It's real. And if you go to the Centers for Disease Control, the CDC, they have a map of the United States that's color coded that shows you the preponderance of stroke in the Southeast, and you can kind of imagine this belt across the country.
Right.
And we're kind of like in the buckle in Tallahassee.
Right. You spent time along your medical journey. You're in medical school. You're studying. You're learning. How did you get into the field of stroke prevention? Is that something you were always interested in, or did it pique your interest as you were matriculating along your journey?
Really, it became a focus of what I do after all my training was done once I was in the community. And so as I went through residency and fellowship, there was sort of a revolution in stroke treatment. So when I started off, like 2004, there was one treatment for stroke, and that's TPA. It's a medicine that we give IV. It helps dissolve blood clots. It pretty much was the only treatment for stroke back then. And as I went through, there were a number of developments kind of along the way in the field of endovascular neurosurgery that proved that some of the procedures we do, where we go in to the artery in the leg and navigate catheters all the way up to the head using X-ray guidance and physically remove clots and blood vessels to restore normal blood flow, that stuff became relevant because it first came out and it didn't look like it. Maybe it's helpful, maybe it's not. And as those things evolved and a couple of different devices came out, it was shown to have a very huge benefit for eligible patients. And so as I came out of training, that stuff was just happening. And so we started doing stroke intervention here in Tallahassee in 2012, just as I started in practice. And, it's kind of interesting because I went to a few conferences that year and I heard some prominent speakers speak about neurosurgery and stroke, because typically neurosurgeons aren't involved in stroke. It was neurologists. And one of them, I remember him saying, in order to be relevant in the next 20 or 25 years, neurosurgeons are going to have to be involved in stroke care. Initially when I heard that, I was like, that's never going to happen. But he was right. As things moved on, as we became more and more involved, it became more of an interest and a passion, and really what it became was there was a tremendous need in the community for a comprehensive stroke center. And so TMH and the administration and my group, Tallahassee Neurological Clinic, sort of partnered together to put together the pieces for a comprehensive stroke center. And so it kind of evolved over the last few years.
Oh, that's great.
Okay,
That's
good.
amazing. That's great. That's great. So with all this, please help us explain to us rather what a stroke is and what causes a stroke. Because a lot of us, we think we know what a stroke is, or we see people with strokes, or we hear about it, about stroke. But what is it and what causes it?
So probably the easiest way to think about this is a stroke is a brain attack. It's like a heart attack. When you have a heart attack, suddenly some blood vessel in your heart closes and you have chest pain and things don't go well. Same with a stroke. It's usually a sudden blood vessel being blocked in the brain that causes that area of the brain to not get blood flow and oxygen, which means you have neurological problems because that part of your brain isn't working. And there's a couple of different types of stroke. There's ischemic stroke, which is roughly 80%, and that's where a blood vessel gets blocked. It could be a tiny blood vessel, it could be a huge blood vessel, but a blood vessel gets blocked with clot or something like that. And then there's other types of stroke from bleeding in the brain, spontaneous bleeding, things like aneurysms that rupture, or hypertensive hemorrhages. So that's bleeding related to having uncontrolled high blood pressure. So there's several different kinds of stroke, but it's really sudden interruption of normal blood flow to the brain that causes sudden neurological symptoms.
Okay, so that kind of leads into our next question, because our next question was the types of various strokes that they are. But what ways can a stroke affect the body? Because most people think that, you know, you watch the little TV, fast, face drooping, all that. But are there other signs, or what signs, or how can it affect the body?
So in reality, a stroke could affect anything that our brain is doing. You could have a stroke where you just have some facial drooping, or you could have a stroke where a patient becomes comatose. Okay, and so it's the whole gamut. But common symptoms of stroke are the ones outlined on those mnemonics like FAST or B-FAST. The B-FAST mnemonic, it stands for balance, eyes, face drooping, arm weakness, speech difficulty, and the last letter T is time, meaning time to call 911. So if you see somebody that suddenly has balance problems, or their eyes are deviated to one side or the other, their face is drooping, they have weakness in an arm or can't move an arm or can't move a leg, speech problems or can't speak, that person could be having a stroke, and you should just call 911 and not worry. That's what 911 is for. It's to come quickly and evaluate those patients.
Right. So like how was that the B-FAST or FAST, how was that like created or developed? Because, you know, we go from a point to where people are looking to be able to identify what's going on, and then okay, we have the identification. So how did that come about?
Well, so really, this came about over the last 20 years or so. That medication we mentioned earlier, TPA, that we give sometimes to treat stroke, you know, that was studied and FDA approved in the 1980s. You know, it's 2021. The majority of patients who arrive to the hospital are not eligible for that medicine for one reason, is they get there too late.
That was the question I was going to ask.
The window for treatment for TPA originally is 3 hours. Okay, so you have to have a witness stroke and you have to be there before 3 hours to get that medicine. And the reason for that is there's a risk of bleeding if you give it beyond that. Now we've studied it more, and the window's a little bigger. Now it's out to 4.5 hours in select patients, but a lot of patients come too late. And so part of that is because maybe you think, oh, you know, they're not doing so well, we're going to let them sleep this off, or, you know, we'll just see how things are going in a few hours. You know, it's not that bad. It's just a little face drooping, and patients wait, and they show up too late for treatment. And so these things like B-FAST, those developed in an effort to raise awareness about stroke so that patients and family take things seriously. They're having a sign of a stroke, that they get help quickly, because the number one treatment, or the number one reason to not get timely treatment for your stroke, is that you show up too late. You show up outside of the window.
Okay. So I want to kind of go back a minute just to make sure I get understanding.
Sure.
A stroke is caused by a clogging of the artery or the vessel. So what causes the clogs? Is it just irregular cell formation? Is it bad diet, the way a person lives, or what causes the clogs?
So there's a lot of different risk factors for stroke. The number one cause is cardioembolic. So that's blood clots that develop in the heart that then get pumped out, and they go to the brain and cause a stroke. And so that's the number one cause, but there's other causes too. Things like carotid artery disease. So the blood vessels in our neck could have blockages. sometimes very small blood vessels in the brain just spontaneously close off from high cholesterol, diabetes, smoking, high blood pressure, or some combination of all of that stuff. And so those are the big risk factors for stroke, though, are heart disease, smoking, high blood pressure, diabetes, cholesterol, diet plays a role in there, exercise, that type of stuff.
Right. Okay. So and thank you for answering it in the way you did, because it leads back to what we've been preaching on here is healthy eating, exercising, drinking water, like healthy living. A healthy lifestyle will keep you healthy from head to toe.
That's right.
So, okay. All right.
All
So
right.
go. My bad. Go ahead.
So can you explain to us a little about the services at Tallahassee Memorial Healthcare for caring for a person who suffers with a stroke?
Yeah, absolutely. So Tallahassee Memorial Hospital is the only comprehensive stroke center in the area, in the region. And we're accredited by the Joint Commission, which is the highest level of accreditation. And so what that means is we provide like the whole spectrum of stroke care for all of the different types of stroke. And so when someone arrives in the emergency department having a stroke or stroke-like symptoms, we call what's called a stroke alert, and a whole series of things happen. We have a nurse practitioner who is in the building 24/7. So we have a whole team of them. They rotate. We don't just make one person stay there all day. We have a team of nurse practitioners. They're there 24/7, and they show up and see that patient immediately when a stroke alert is called. They do a basic workup, some scans, certain types of CAT scan, and they call one of the stroke doctors, and we review all that with them. Usually we see the patient too in the emergency department, and then we decide, okay, what do we do? TPA, does this person need a procedure like a thrombectomy? Do they need both? Or, are they out of the window? Is the stroke already over? That type of thing. But really, Tallahassee Memorial offers the whole spectrum of stroke care, in the region.
You said something about a thrombectomy. Did I say it right?
A thrombectomy.
A thrombectomy. Can you explain what that is?
So a thrombectomy, that's the procedure I alluded to earlier. And so sometimes some of the major blood vessels in the head or neck are blocked, causing a stroke, and that's something called a large vessel occlusion. So for example, the carotid artery gets blocked off at the head, or maybe it's the middle cerebral artery in the brain, which is one of the major arteries in the brain. So when a major artery is blocked, we're not sure that TPA medicine is effective because there's such a huge plug. And so a thrombectomy is a procedure where we physically go inside the arteries all the way up into the head with some specially designed catheters and devices to remove that blockage. And sometimes it's from a suction, almost like a little shop vac, if you will. That's called aspiration. Or we have another device called a stent retriever. So there's a couple of different ways of performing a thrombectomy, but it's removing a clot or a thrombus from an artery in the brain.
Okay.
Right. And like you were talking, being able to evolve the technology, going from the TPA to the thrombectomy, like that's a total change. So you're saying you go in through the groin area, or there's a specific artery in the leg or in the groin area that you go into to get to the brain, or?
Yeah, so normally we go through the femoral artery, and so that's the artery you can probably feel in your groin that pulses. It's where you get the pulse down there. So we go through that femoral artery, and that goes right up to the aorta, and we go up the aorta, which is the main artery basically in our chest and abdomen. We go all the way up to the blood vessels that are going to the head. So at the top of the aorta, we have the carotid arteries going up to the brain, and then the vertebral arteries. And so depending on where the blockage is, and we usually tell that from one of the CAT scans that we get earlier on, we go up whatever the appropriate artery is and then remove the blockage.
Okay. So, okay, the first time you were performing that, like what was going through your brain? What was going through your mind? Like how were you feeling? You like, okay, I'm about to navigate this person's their artery system. So, like, kind of take us through how were you feeling and just your mindset going through that your first time?
Well, so it's interesting. So during my training and fellowship, we did all sorts of angiography, mostly for aneurysm treatment and things like that, which is a little different. As I was going through my fellowship, this whole thrombectomy idea was sort of evolving.
Okay.
And the first stent retrievers, which were devices to remove this blockage to perform a thrombectomy, those really got approved in like 2012, which is right when I came to Tallahassee.
Right.
And so I had done them on a little model, a demo, but I had never used them in a person before. And here I am in Tallahassee, and a gentleman came in having a stroke. And at the time, neurology was involved, and they got all the right pictures and said, hey, this person has this middle cerebral artery occlusion, and we think they would be good for a thrombectomy. And so we took him straight away to the vascular lab where we do these procedures. And I'm thinking, oh my God, I've never used this in a human being before. I've used it in a pig, in a lab,
right.
in Atlanta. So hopefully this, we'll give it a go. Now, that particular case was a home run. That guy, when we started, he looked terrible. There's a scale of stroke severity called the NIH stroke scale. He was a 20, which means he had a 1 in 3 chance of dying. Like, he was bad off. The next day, his stroke score was a 1. He made a dramatic improvement. He was almost normal. No, it was literally a home run. So the first time I ever tried this, it worked great. Now, in reality, you don't always get a home run. Sometimes it doesn't work. Sometimes, it doesn't, you can't get the blood vessel open. Sometimes you get some of it open. Sometimes you hit a home run. But for that guy, it went phenomenally well. And, it was amazing to see that. And I think my interest in stroke improved right after that, because we're like, holy cow, this can work. We can help people.
Right.
So I have a question. You said you go to a stroke lab. So what's so like, is it a procedure that's done like in the ER or like in the OR, or is it like how they do kind of like a cardiac cath in the lab?
Well, so it's sort of like the cardiac cath in the lab. However, it's in the OR. So we have 2 what are called biplane fluoroscopy suites in the operating room, and then Mushkin Center, which is the new part of TMH. 2 of those down in the operating room, and that's where we do these procedures.
Okay.
And they're set up. Oh, sorry.
Oh, go ahead.
And they're set up very similar to a cath lab, like a cardiac cath lab. They're just located in the OR.
Okay. And then about how long does like a procedure like this take? Is it vary on the person or where the clot is? Does that all vary, or is it all about the same amount of time?
So it varies on the person based on how well that clot comes out. But usually from the time we start the procedure to the time we are doing the very first attempt to open up that blood vessel, at our institution, it ranges between 15 and 30 minutes from when we start to when we're removing clot. So if things go well, the procedure may be done in 30 minutes.
Okay.
And if it's harder to get out, it may take a lot longer than that, or we may not get it open. But, within a very short period of time of starting that procedure, we're trying to open up that blood vessel.
Okay. Now that's like, my mind is just
blown.
Yeah, because I got the pictures in my head the best I can, trying to picture it. But no, it sounds so cool. But it's eye-opening as well, because I want our audience to understand this is what you will have to go through if we don't take our health serious. If we're going to go through and have strokes, if we're having strokes, these are some of the procedures and things that could happen. I had a friend who had a blood clot in the lungs and had to go through the procedure to get it removed. But I'm just, that was tough on her, but just imagine it going into your brain. So health, we need to be healthy. So with that being said, when a person suffers a stroke, what are some kind of rehabilitation treatment, or what type of care does a person go through once they've had a stroke?
So once someone's had a stroke, after we get through those first couple of days in the hospital, then really the focus becomes rehab and recovery. And that starts in the hospital, where physical therapy and occupational therapy and speech therapy, they see and evaluate these patients, and they decide, okay, what does this person need going forward to recover? Could they go home and have some outpatient therapy, or did they have a major stroke? Do they need to go to an inpatient rehab facility or something like that? Rehab after stroke, though, is very important. We know that when you have a stroke, there is potential to improve probably for up to a year, but it's dependent on rehab and hard work. And we know that patients who don't get therapy, who don't get rehab, don't have as much improvement. And so the rehab piece is really important. The other piece that's really important, I think, is identifying, why did this person have a stroke in the first place? Because about a quarter of the patients having stroke every year in the United States, it's their second one or third. It's a repeat stroke. And so identifying the cause of stroke and treating it to try to prevent it from happening in the future, I think that's something that we really need to focus on, and could really help our community, because literally a quarter of the strokes, those people have already had one. So
because that was another question I was going to ask, because I know from personal experience, my dad had a stroke, and it was more or less like, I really wasn't educated on strokes. So he was like, I just want to lay down, just pick me up and let me lay down, I'll be fine. And so I was like, okay, like you just fell in the bathroom, let me just get you up, get you to the bed. Not thinking about it was a stroke or anything until we woke up next morning and half his face was drooping. And so it was like, so for people who say they have a real bad stroke and then they recover, I think you kind of answered the question, but they can have another stroke again. But is it guaranteed that it's going to be as bad as the first one? Or if they have a light stroke and the next one's going to be another light stroke, or it could be either vice versa? Because, most people think, oh, I had the big one, I'm good, so I might not have another big one.
No, I think I had the big one, I could have another big one. And It might be the last one I have, because stroke is still a major cause of death. And so identifying the cause of stroke is a really important thing. And that's what a lot of the patients who come in having these minor strokes, they get admitted to the hospital, but maybe their symptoms even go away. And they didn't have a stroke. They had something called a TIA, or a transient ischemic attack, or sometimes in the community people call that a mini stroke, but it's not really a mini stroke. But they say, well, my facial drooping and my arm weakness, it's gone, it's better, I'm fine. I want to go home. But usually we have multiple things that we need to check, because that's a red flag. That's a smoking gun. You had a warning. You had a warning, and we need to look at everything and make sure that that we've evaluated your heart rhythm, that we've done an echocardiogram, that we've evaluated your carotid arteries, and make sure that we've looked at the common causes of stroke, because you have to take that opportunity to make sure that if there's a potential cause for stroke, we get that treated, so that person doesn't have a big one the next time.
Okay.
Right. Now that's key. Because I know a lot of people who've had strokes, and it's like, it's separated. Okay, the so-called mini stroke. Okay, we can get over that. Yes, I've had a stroke. It's almost like once you reach a certain age, you're supposed to have had a stroke. And it's like, well, no. And then there's the category of the people who've had severe strokes. But the idea is, just don't be stressed. If you're not stressed, then you won't have a stroke. So can you just like help further dispel that?
Yeah. Or like, what are some of the myths? Like, because that's the big thing in the community is people have those myths. Oh, well, I cut out the salt, so I'm not going to have a stroke or a heart attack. Or I'm exercising, I'm not going to have a stroke or a heart attack. Because I've seen some healthy people have heart attacks and strokes. So it's just like, what are some of the myths that we can dispel to the community about that?
I think one of the bigger myths is that stress causes strokes, because if that were the case, all the neurosurgeons in town would have strokes.
Right.
We have a stressful job. But no, seriously, we don't think that stress necessarily puts you at risk for stroke. But like those other things you mentioned, I cut out the salt. Well, salt's important for, maybe your blood pressure. But at the same time, most patients who are at risk for stroke or have had a stroke have multiple risk factors. They maybe they're obese, or they have diabetes, or they have both, or their diabetes isn't under control, or they smoke, or usually there's a whole number of risk factors. And I think that people need to sometimes be honest with themselves about, okay, look, I need to get some weight off. I do need to exercise, and I need to check my blood sugar, and I need to take my diabetes medicine, and I need to, stay on the wagon, so to speak. It takes effort, and it's hard.
Gotcha. So it's not the old wives' tale of the stress, because to us we've been told it so long, it just made sense. Stress, stroke, stress, stroke. It's like they're supposed to go together. It's like, oh well, hold up, because as we're talking and I'm listening to him, I'm like, hold on, well, let me ask this question, because it don't seem, as the way he's talking, doesn't seem like stress is as big as factor as the community would make it think. But you're saying it's a compounding of different things going on in the body at one time that can lead to it.
Usually, most of the patients that I see that have had strokes or having a stroke, they've got multiple risk factors.
Yeah.
And some of them are things you can't do a whole lot about, and a lot of them though are preventable. Smoking, blood pressure control, diabetes, diet, that stuff, we have control over.
Okay. So being that you were 2012, you're able to see the new technology when it comes to treating strokes. What's happening in the future? What new things are you excited about that may be coming out, or that you could talk about, or ideas that may be on the table to helping to prevent or even treat strokes in the future?
So in the future, well, first of all, the devices that we use for thrombectomy have gone through multiple generations of improvement, and I think that will probably continue. We get better and better at doing the thrombectomy. Then each year, the devices that we use are better than the year or two before. So that's really exciting. I like to see that, innovation in the field. That, I know next year, whatever we're doing, it's probably not what we're doing right now. Okay, and hopefully it's better.
Right.
The other thing is, the surrounding hospitals don't necessarily have all the services at TMH, but they still get patients having strokes, and some of those patients need care at TMH. And so there's actually some really exciting, computer algorithms that look at these scans and help predict who might need a thrombectomy and who might not need a thrombectomy, that we're trying to get up and running, that might help expand the reach, so to speak, to some local hospitals to help more people.
Okay.
That's cool. That's cool.
Right.
Yeah. That evolution is key though.
It's just seeing how things transform. If we really sit back and look from 2012 to now, how we have evolved. It's like, where were we at? How did we do what we did without this? And so just looking at some of those things. So is there any other information about TMH Comprehensive Stroke Services that you want to express to the community, so we could try to get it out there? Because I feel like it's a great program you guys have. It's just few people know about it. So what are some of the things that you really want to express to people in the community about the TMH Comprehensive Stroke Services?
I think the most important thing to stress to the community is that if you think that someone is having a stroke, you need to call 911. Okay, and it's very simple, and it doesn't even necessarily have anything to do with TMH, right? It's just more of a basic principle. If you think someone's having a stroke, you need to call 911. Stroke is an emergency. It's not something to sit down and see if it gets better. If somebody's got those BFAST symptoms, the balance, the eyes looking off one direction, face drooping, arm weakness, speech difficulty, it's time to call 911. That's the most important thing anybody can take from this is if you think someone's having a stroke, call 911.
Okay.
Okay.
All right. So before we wrap this up, just do you have any tips, best practices that you would give to the audience to help them either prevent and or best recover from strokes?
Well, so from the prevention standpoint, I think that it's important to see your doctor. Even healthy people or people that think they're healthy. Make sure you see your doctor, have your cholesterol checked, have your blood work run, that sort of thing. Identify risk factors and try to treat them. And that doesn't just prevent stroke, that prevents a whole host of medical problems, right? Stroke is really a small part of vascular disease, and that includes cardiovascular disease for your heart, stroke, peripheral vascular disease in your, the rest of your body. And so, see your doctor.
Okay.
So how do people get in? So you like a star around here. You pioneer, definitely pioneer.
Right.
We do want to make sure that we give you your flowers and we give you your just due, because the services that you and your colleagues have brought to Tallahassee. I'm a native Tallahassean, so I always want to take time to thank people who bring things to my city that we never really had before. I've seen the city grow over the years, seen a lot of innovation come to the city, and we're definitely in a better place than we were when I was born in 1984. So just once again, thank you. But how do people get in contact with you if they want to learn more about you or they want to have you on their podcast?
So if they want to learn more about me, they can look at my website. It's MatthewLawsonMD.com or the TMH website, tmh.org. And I practice at Tallahassee Neurological Clinic. So we see patients there. But really for a lot of patients for stroke prevention, it probably starts with just their primary care doctor. Make an appointment, see your primary care doctor, and kind of go from there.
And remember, guys, if you don't have a primary care physician, you're always local to look up www.neighborhoodmedicalcenter.org. We're here to help. We see people with insurance and without insurance. So if you don't have that person or need that medical home, look us up. We're right here in your backyard, right in your corner. We're right around the corner for all your healthcare needs. So just look us up and we'll be able to do that. You can call us at 850-224-2469. Again, 850-224-2469, and we can make your appointment and get you into care.
He's like a commercial that
Yeah.
That and all the addresses like the back of his hand.
Well, that's what you're supposed to do.
It seemed like you have that memorized.
I do. It's just trying to make sure that people, saying anytime anybody say, "Oh, so what do you work at?" The next question will be, "Do you have care?" You don't? So let's see how we can get you in care. Let's hook you up. Let's do what we got to do.
Yes.
Because like you say, it starts at home with primary care. And that's part of our job as a community health center is to lower those comorbidities for people and to keep them out of the ER with strokes and other issues that's going on with high diabetes levels and high blood pressure and things. So if we can get them into care, we can work together. Or if they come to you, then you can get them to us, and then we could be like, you know what? Let's try to keep them out of there from reoccurring from those same problems.
Yeah. It's amazing how many people don't have a primary care doctor that come through that have a stroke, that, they have a stroke, their diabetes is not controlled, they have high blood pressure, their cholesterol is terrible. They don't have a doctor. they're leaving the hospital. And so one of our nurse practitioners, my nurse practitioner, has a stroke clinic, stroke follow-up clinic, where people who get discharged from the hospital who don't have a doctor, they come and see us. In fact, we're trying to get even people with a doctor to come back and see us at least once, just to make sure that, you know, all the I's are dotted and the T's are crossed, and that, okay, you had terrible diabetes. Do you have your diabetes medicine? Are you taking your diabetes medicine? You know, how can we get you hooked up with a primary care doctor? That sort of stuff. And so it is amazing to me how many people don't have access to primary care. We do the best we can with the stroke patients that come through, but I know it's a big problem.
Yeah.
So with you as a physician, most of the people that you see, they have insurance too, correct? So, and they have insurance, so they don't have access to they have access to the doctor, but they just don't utilize it. Is that what you're saying as well? Or is it majority uninsured?
Both. There's a lot of uninsured patients out there. Obviously, if you're having a stroke, it doesn't matter if you're insured or not. You call 911 and get to the hospital, and we're going to take care of you either way. Okay. But you know, for the patients that don't have primary care doctors, some of them have insurance and they've not taken that step and gotten a primary care doctor, or they think I'm healthy, I don't worry about it. I don't need to see a doctor. And maybe they're not that healthy.
Right. Right. All right, cool. Thank you. Well, thank you once again, Dr. Lawson, for taking time out of your busy schedule to come hang out with us and have a great conversation about stroke prevention and about the TMH and all the stroke services and prevention that you provide. And just reminding everybody, this is Mind Your Body and Soul, your favorite podcast. And we are an educational podcast that focuses on all things health related to help our listeners learn more about the various health topics and information they may not have access to. We seek to inform, empower, uplift, and mobilize our listeners to become the healthiest versions of themselves. Remember, every Wednesday, check us out on our website, www.nmcpodcast.com, as well as our parent website at neighborhoodmedicalcenter.org. We're also available on Anchor, Breaker, Radio Public, Pocket Cast, Spotify, Google Podcasts, and of course, YouTube. Make sure you subscribe, like, comment, and share the video, because I guarantee you learned something today. So with that being said, thank you, Dr. Matthew Lawson.
Thank you.
Thank you for having me.
Oh, no problem. This definitely was our pleasure. Thank you for being part of this podcast. And we will see everybody later. Peace out.
Sounds good.